Very good morning to everybody attending to this symposium. First of all, I would like to say thanks to Rector of the SME, Professor Karna Kiangcho, and Commanding Officer of the number 1 DS UGCH, Professor Karna Kiticho, who giving me a chance for this talk, as well as Professor Karna Kimpibia, Professor and Head of Department of the Medicine, and all other my colleagues supporting to me. Today, the topic that I say is overcoming the new medical challenges posed by the COVID era. I am Major Diwon from number 1 700 Military Hospital, PUWIN. This is the outline that I discussed. As you know that the COVID-19 is a very emerging disease like SARS and MERS. The clinical symptoms are very notorious to determine, whereas asymptomatic to multi-organ failure and death. Most of the presentation is acute respiratory symptoms and the flu-like illness. So the content history is a very important one, and the acute incubation period is 5 to 14 days. The first onset of the clinical symptoms is very crucial to determine treatment decision, especially who has underlying multiple comorbidities. The respiratory phase is usually started 2 to 3 weeks after the symptom onset, and the cytokine storm will be possible after 2 to 3 weeks later. The estimated reproductive number is 3, which means more transmissible than the common flu. As well note that the main site of the viral entry is the ACE2 receptor with the help of the enzyme of the TMPSS. The ACE2 receptor is a much more abundant in the lower respiratory tract, GI tract, the nervous system, and vascular endothelium. So their clinical symptoms are much more variable depending upon predilation site of the entry and individualized genetic susceptibility. Moreover, the spectrum of the COVID-19 is also depending on the rate of contagious spread and the immune status of the victim. This is the figure show various spectrum of the symptoms of the COVID-19. There is no definitive biomarker have been used in the COVID-19, but there are main supporting indirect parameters rising in the COVID-19, such as absolute neutrophil count, the dimer level, C-reactive protein, ferritin level, LDH, and the AST during the timeline course of the COVID-19. So what medical challenges are facing in the COVID era? When PUI patients came to the routine obesity visits, all doctors are screened for the PUI to follow the guidance of the MOHs. Every military hospital made standard operative procedure based on the MOHs guidance. And we also collaborated with the public sectors and social health workers in the clinic in time. We also opened the designated hospital and quarantine center and accepted all the PUI patient and COVID positive patient. Non-PUI patient could be admitted to their respective hospital after initial PCR swab negativity. Treatment and hospital discharge will be followed according to the guidance of the MOHs. This is the figure of show MOHs guidance updated on 25th August 2020. So this is the flow chart of the Viva Clinic screen in OPD patient of number 1, DSGH. You will see that if the patient has a PUI with a positive PCR, we shifted the patient to the isolation ward and designated hospital. If the patient is non-PUI or this swab is negative, we place on the medical ward 3 and then shifted to the respective ward after 2 times, second times subsequent PCR negativity. And then we have done that 3 to 4 times subsequent PCR checking during the admission and then discharge. This is the routine screening of the hemodialysis patient and their caregivers before going to hemodialysis. If the patient had PCR positivity, we shifted to the isolation ward and designated hospital and made the routine hemodialysis. If the patient is PCR negative, we place the patient to the renal medical unit and routine HD was done and then discharged. The cardiac unit and other specialty units are making standard operative procedure and drawing the guidance depending on the available resources, which could not too much betray with the international standards. So how many shortages we had found on the routine care? There are 6 main shortages are very challenging in routine medical care and practice. These are shortages in medical equipment resources. There is an ever-changing of the treatment There is a doctor-patient relationship distortion, and the delay admission or transfer to specialized medical unit. There is a limitation to the criteria in the patient selection, and there are several factors in decision-making delaying process. So another challenge is the diagnostic challenges. Because of the highly contagious spread of the disease, there are much more limitation in routine investigations and operative procedure. Thus, both COVID positive patient and non-COVID positive patient have been facing sometimes in delay routine medical care and surgical procedure. But we could do the best manage to overcome these delaying by joint cooperation with other specialties during the crisis. Another challenge is a problem challenge. Although some patients have symptomatic for COVID, but repeated nasal swab for PCR repeat negativity, and then after subsequent detection show suddenly positivity during the hospitalization. Some patients admitted for other reasons, that is no PUI symptoms, but they are nasal swab for PCR repeated screening repeat incidentally positivity. So how could we be handle these problems? The following possible explanation could be considered to handle this problem. The patient could be asymptomatic. It could be unknown symptom onset. It could be improper recollection of the nasal specimen. There is a failure of the contact transmission by near person or caregiver. There is failed to detect virus shedding area regarding to the time window. Another prevalent challenge is previously infected individual had RT-PCR positivity after 2 weeks following hospital discharge, and some non-infected individual will be RT-PCR positivity after 3 to 4 times subsequent PCR negativity during admission. So there is a risk of one of the question. Does this reinfection or relapse? All of you know that these heavy antibodies to the virus may provide protection from getting infected with the virus again. But even if it does, we do not know how much protection do antibodies may provide or how long the protection may last. Confirmed or suspected cases of reinfection have been reported in some study, but remain rare. These are the possible concepts after the COVID infection. One is inadequate immune response. It could be viral detection by the viral remnants. It could be reinfections. It could be relapse. So medical personnel and their family members are living under the influence of the viral trees during the COVID era. The figures show the possibility of the COVID positivity depending on the time and rate of specimen collection. And as well as the following figures show the timeline on the body response of the COVID infection, although we still have lack of the exact knowledge and long immune response of the COVID, but the time frame can help to decide the COVID plasma therapy, and we need to do research or review for further immunization response of the COVID. This is the scientific report show the possible explanations of reactivation and recurrent positivity for the COVID-19. Another challenge is the treatment challenges. As we know that low-dose dexamethasone and nitrosamine oxygenation have improved for benefits in the treatment of the COVID. Convalescent plasma therapy, remdesivir, tocilizumab, and other newer agents are still conflicted in proven benefits, and then need a lot of the ongoing trial for short-term and the primary endpoints of the therapy. This could be the main challenge in treating of the COVID-19. Another challenge is the long COVID syndrome. When the COVID positive patient have persistent symptoms more than 3 weeks, and all the symptoms of the following have beyond 12 weeks, could term as a chronic post-COVID syndrome. It is a multi-system syndrome and could become as a challenge and need a multifaceted approach to tackle physical, cognitive, psychological, social, and vocational domains of this health condition. Another challenge is the response challenge. In response of the COVID outbreak, government military sectors adopted strict lockdown policies, prevented to mass gathering, banned to public events, closed all schools, public buildings and business, and restricted to all travel. As a result, many patients were unable to access routine OPD visit service. Some patients have reluctant to admit hospitalization, and some patients have suspended for some medical categorization, and some patients have delayed necessary treatment, such as surgery, dialysis, and the cancer treatment. Another challenge is the healthcare resources challenges. The rapidly growing imbalance between supply and demand of medical resources and counter resource strain becomes a challenge, and the diagnostic, therapeutic, and preventive intervention will also be scaled. So how could we overcome these hospital shortage? The responsible teams are delivering alternative care methods and making selection for vision as priority to ease resource strain challenges such as ventilator requirement for the ERDS patient. Another challenge is the ethical challenge. To the individual safety rather than the collective security and dignity become as ethical challenge between the doctors and the patient. This became as a distorted relationship in the treatment, but we do minimize this issue in military settings by giving proper care for the patient's safety. There are four main ethical encounters have been problematic around the medical fees around the world, such as justice and equity, error, confidentiality, and autonomy. But our military sector assure that good medical practice can do the best to overcome these four encounters in COVID crisis. Psychological distress as chaplain. Frontline healthcare workers face psychological distress due to uncertainty about pandemic duration, extended workload, feeling of powerlessness, fear of transmitting the disease to their loved ones, and lack of effective specific treatment. These factors are making the medical shift to the pandemic blues and psychological support to overcome these challenges. Another challenge is educational challenges. Digital front as well as virtual care has rapidly adopted digital care healthcare solutions became as a proactive care for the best interest of the patient at remote area because of its robustness, safety, credibility, and fairness. Another challenge is immunization challenges. More than 100 vaccines have been developed, with the biggest challenges is to determine which vaccine is ideal. Another challenge is who be ranked the first priority to receive vaccination across the community. Before giving to the whole immunization to the community, the practical measure is to avoid mass gathering to prevent as herd immunity. So what about the new normal style? We could do daily tests with the preventive approaches, what we call a new normal style. We need to obey the guidance of the MOHS statement until the clearance of the COVID outbreak. These are the photos of the new normal style in daily living ways of the medical practice. In the clinical committee and teaching, health education to religious settings and the public settings. A new normal style of the medical examination and the convocation style and the covalent plasma therapy team at the number 1 DSGH. Another challenge is choosing of the cool and the hot site. Cool site deliver non-COVID care, operate efficiently without interrupting acute work and create capacity for elective procedure. Hot site deliver as COVID care, including all treatment with their needs and the strict precautions. Multifarious approach. No one can predict that one pandemic is supposed to control. There would need a massive effort even though the vaccine was found. Community leader, print media, government, and you around the world have multifarious approaches to struggle how to reopen their economic by stay containing the virus. Education problem, nutrition, and health consequences and economic recovery are unexpected challenges for after the COVID era. Thus, everyone should contribute to stopping this pandemic. Future perspective. We have done the best, but we hope for preparing another wave can be. It could be fourth wave or so on. One sure thing is the geopolitical, socio-economic dynamics, humanity value, and health investment what we emerge as a new form after the COVID. To control the growing of the further pandemic waves, we avoid 3C, avoid crowded places, avoid close contact, and avoid confirmed and unclosed places. So in conclusion, to overcome the challenges, we should to be adaptation with the new normal style in daily living for learn and the control of the COVID-19. Thank you very much for my presentations.